Hello, everyone. Thanks again for attending tonight. I'm here to present Dr. Adam Weiser. He has completed his undergraduate studies at Northwestern University before attending Rutgers Robert Wood Johnson Medical School. And after completing medical school, Dr. Weiser went back to Northwestern to complete his residency in urology and internship as well. Dr. Weiser has been practicing in Columbus since 2003, and I want to take some time just to quickly thank you again for your time this evening, Dr. Weiser, and I'll turn it over to you now.
Thank you so much. I know each and every one of you is extremely busy and have many things to do each and every night. And it's my pleasure to be able to talk to a hopefully receptive audience about something that I'm exceedingly passionate about, which is men's health. And in this case, how to improve men's health through the treatment of prostate cancer. And most importantly, allowing men to have their cake and to eat it too, by not only being safe and well and treated from prostate cancer, but also trying to help them to minimize the nasty side effects that sometimes occur with this disease process and its treatment. We're going to talk about a few things tonight. Prostate cancer in general. With that, we need to know what exactly is a prostate and where it's located, statistics about how prostate cancer affects men throughout the world, and in particular the United States, and to drill down, Central Ohio, how one is diagnosed with having prostate cancer, what are the options for therapy, and then we'll get a little more detailed into the treatment option of radiation therapy for prostate cancer, and how something that I'm really passionate about, SpaceOAR Hydrogel, fits into that treatment in helping men to not only overcome prostate cancer, but also to thrive and not, and I repeat, not to have many of the major side effects that are associated with treatment of prostate cancer. So where is the prostate? What is the prostate? So first off, prostate is a male-only organ. We're not even really sure what the prostate does. We think the purpose of the prostate is to liquefy semen. We urinate as men through our prostate, and we ejaculate through our prostate. And as the ejaculate goes through the prostate, it combines with a chemical enzyme called PSA, or prostate-specific antigen, and becomes further refined and further liquefied in order to have us be fertile and have children. For the price of that, the prostate gets to sit in some pretty rarefied and important real estate. It sits beneath the bladder and just in front of the rectum. So this tiny little walnut-sized organ sits literally at the center of it all, the heart of it all, much like Ohio is in the United States, the heart of it all, right in the pelvis in a very crowded, dense area. And really all of its neighbors carry out exceedingly important functions. Unfortunately, about 1 in 9 men will be diagnosed with having prostate cancer throughout his lifetime. And that's the second leading cause of cancer death in the United States, behind lung cancer. So a tremendous number of men within the United States are both diagnosed with prostate cancer and sadly will ultimately die from prostate cancer if left untreated. In the US, approximately 165,000 cases per year are diagnosed, and that's really been relatively stable over time. The deaths per year, fortunately, are starting to go down, and they have started to go down over time, and that's part and parcel due to testing and early diagnosis. But even with that, roughly 30,000 men a year die from prostate cancer. Prostate cancer, as I tell patients, often can be thought of as a Clint Eastwood type of disease. There's good, there's bad, and there's ugly. For those who are diagnosed early with localized, low-grade disease, the 5-year survival rate's over 99%. If you combine that with the survival rate for all stages, it is upwards of 99%. And at 10 years, 98%, if indeed you find things at a localized early stage with low-grade disease. However, patients who have more advanced disease can often have worse outcomes. And so it's exceedingly important for me and my colleagues as urologists to try to make a diagnosis of prostate cancer when it's at its earliest and most curable. So how does a urologist make a diagnosis of prostate cancer? Well, we go through a process of screening men, which is really trying to detect patients before the patient manifests any symptoms. We use two very basic tests. One is a blood test called the PSA, or prostate-specific antigen. That same chemical, that same enzyme that helps liquefy semen, well, in the 1990s, it became commercially available as a laboratory test. And what we found is that there is a correlation between men with higher PSA scores and men who harbor prostate cancer. So an elevated PSA can sometimes be the first screening test that is used to identify if a man has the potential of harboring prostate cancer. The other basic test is the simple prostate examination, which is a digital rectal examination. Many men often feel ashamed or often are, frankly, squeamish about having a prostate exam. Trust me, urologists aren't necessarily jonesing to do prostate exams all day long. But what I can tell you is that tiny digital rectal exam, which takes just a brief moment, can provide a tremendous amount of information in helping to screen for prostate cancer. We sometimes, unfortunately, make the diagnosis when people have symptoms such as difficulty with urination, slowing down of the stream, not emptying the bladder, blood in the urine, painful urination. Once we are suspicious of a man harboring prostate cancer, we will ask the man through an informed decision-making model to give us permission to perform a biopsy of the prostate to confirm the existence and, if present, the severity of the prostate cancer that the man holds. Two basic traditional approaches for prostate biopsy. The most common is what's called the transrectal approach, which is where a small ultrasound probe is placed into the rectum, and alongside or through the probe, a needle is placed that goes through the rectal wall and into the prostate. Or the increasingly common transperineal approach, which is that small bridge of skin that sits just below your scrotum and just above your anus, is called the perineum. Well, if one is to put a needle directly through the skin there, and of course the skin is numbed up, the needle traverses the skin and the tissue beneath it and goes right into the prostate. So if you can imagine, you literally are sitting on your prostate, and with ultrasound guidance, the needle can be placed in that perineum and very safely take a series of biopsies of one's prostate. So how do we determine how severe the prostate cancer is? So after the biopsy is performed, a physician called a pathologist will look under a microscope, and with the aid of a microscope and staining of the specimens can determine if and when the patient has prostate cancer. And we talk about two forms of looking at how severe prostate cancer is. One is called the grade and the other is called the stage. The grade is sort of like a beauty pageant. And to harken back to my friend Clint Eastwood, there's good and there's bad and there's ugly. With grading, the pathologist gives a score called the Gleason Score or grade group, which lets us know whether the cells are low grade or not aggressive cancer, intermediate grade or more aggressive cancer, or high grade or the most aggressive and frankly the deadliest type of cancer. Additionally, depending on what the grade of the disease is, what the man's PSA is, as well as contributions from the man's prostate examination, we stratify or stage how we think the cancer is advanced within the body. Is it localized to the prostate only? Do we think it perhaps has extended out from the pelvis? Has it gone into the lymph nodes or the bone or other organs? And based upon what we think the stage might be, we'll sometimes incorporate imaging studies such as bone scans and CT scans. There are other things your urologist may use to help determine the severity of one's prostate cancer, such as genomic testing, or literally looking under the hood at the genes that actually power the engine that is the cancer, how aggressive or not aggressive those genes are. PSA velocity, which is just a fancy way of saying how fast has the PSA been rising over the past year or two. Volume of tumor, or how much actual cancer one finds in each and every one of those specimens that's taken from the needle core. And there are more and more new and varied means of determining severity for prostate cancer, and these can be discussed with your urologist. Common treatment options basically fall down into three categories. Active surveillance, which is merely looking at, in this case, lower grade cancers, the type that without treatment probably will convey 99% survival at 5 years plus, and saying to the patient, yes, I know you have cancer, and yes, I know you're concerned, but more than likely, this cancer is not going to materially hurt you. It's not going to kill you. It's not going to affect your quality of life. What we need to do is just monitor this disease, and hopefully, this will really be nothing to be concerned about, that it is not a wolf in sheep's clothing. When one talks about options, though, for cure, meaning the disease process is of the nature that we don't think watching or surveilling the disease is a prudent option, surgery and radiation are the two tried and true areas, and the rest are really all commentary. Surgery, briefly, is just removal of the prostate, of which there's many ways to do it, whether it's open surgery, the way I was taught in the days of the dinosaur, or robotic surgeries. And those two can be discussed with your urologist. What I'd like to concentrate on, though, is radiation therapy, which has, frankly, in 50 or 60 years, gone through many evolutions, many revolutions, and frankly, has gotten better and better and better over time. No matter what you choose to do, if, God forbid, you're diagnosed with prostate cancer, I tell all of my patients you need to know the risks and the side effects of treatment options, and need to be able to weigh those versus what benefit you derive from the therapy that you choose. So understanding how important it is that if, God forbid, you get the worst side effect versus the greatest benefit. Radiation therapy comes in many different flavors. Surgery, as we talked about, comes in several flavors. When one compares the two of them as to what's better or what's worse, I want you to recognize, back to our original slide about where the prostate is and what the prostate does, because it sits in some high-priced real estate, there's a chance for direct damage, injury, or side effects related to bowel function, because the prostate sits in front of the rectum, urinary function, because the prostate sits below the bladder and you urinate through the prostate, and sexual side effects, because the nerves that control erection run alongside of the prostate, and one also ejaculates through the prostate. So again, this tiny little walnut-sized organ sits at the Park Avenue of real estate, and because of that, any type of treatment, anytime you're doing something to the prostate itself, it may cause the neighbors to have a little bit of a problem. Radiation is what, again, I'm passionate about and very interested in talking to you about tonight. And so I want to give you a little bit of overview, a little bit of background into radiation therapies for prostate cancer. Radiation basically uses incredibly precise and directed high energy X-ray to kill cancer cells. But one has to realize, in addition to killing the cancer cells, it can often harm the surrounding normal tissue. And the reason, again, we're sitting in a very confined, tiny space. Radiation often causes, even with the best of intentions to kill the cancer only, damage to the rectum. So when we're talking about damage to the rectum, we're talking about diarrhea, we're talking about blood in the stool, we're talking about rectal leakage of feces. These are not attractive things to talk about. And that's one of the reasons why I'm excited to talk to you about SpaceOAR tonight, which we will get to very shortly, because SpaceOAR is really one of the first breakthroughs in medicine to stop or to limit these side effects. Urinary dysfunction with radiation. You may have increased frequency of urination with radiation. You may have burning or pain when you urinate, blood when you urinate, or urinary incontinence or leakage. Again, SpaceOAR does what we have hoped it would do, which is limits or completely eliminates those problems. Types of radiation therapy. You can see here, this is looks like a menu or an exhaustive laundry list or honey-do list of different types of radiation. I'm not going to get into all of them, but suffice to say, basically what it comes down to are external sources. So imagine lying on a table and directing very precise X-ray beams at the prostate. And these can be done at very low doses over an extended period of time, or very high doses over a very limited amount of time to give roughly the same amount of radiation. In cases where you and your urologist and radiation oncologist do not choose external beams, there are internal sources. The common term is brachytherapy, which are grain of rice size implants that are placed through the perineum and into the prostate. These grains of rice are supercharged with either low dose or high dose radiation, depending on the severity of your disease, that decays over time. So it gives out a charge of radiation that lasts for several months, so that ultimately, although the implants remain within your prostate, unbeknownst to you, over time, that radiation goes from a higher dose down to 0. Again, this MRI CT overlay shows the problems with radiation. And as you can see, particularly here on the right side, the prostate sits right underneath the bladder, sits where the urethra goes through it, a river runs through it, sits where the bulb of the penis, where the erectile nerves jut out, sits right in front of the sphincter of the anus. And again, in the picture at the left, sits right in front of the rectum. So the potential for toxicity, the potential for side effects is quite great, left to radiation's own devices, left if, God forbid, things got out of hand. But we're here to tell you that things are not going to get out of hand, that we are constantly working exceedingly hard to maximize the dose of radiation that can be given to you safely and minimize the number of side effects. In the real world, sadly, roughly 32% of men will experience urinary complaints following radiation. Roughly 6% of men will have GI complaints, the rectal complaints that I spoke of earlier, with radiation therapy. However, with SpaceOAR, which I'm about to talk to, those toxicities have been cut dramatically to where only fewer than 1% of men have GI-related toxicities. And then fewer than 15% of men have urinary toxicities. And frankly, most of the toxicities are transient, self-limited, and can be treated with medical therapies and are not permanent, which is really an exciting development. So first off, when people hear SpaceOAR, they're wondering, what does that really mean? And I think SpaceOAR is a really cool name because space, we tend to think of things with advanced technology, but why are you associating this with an OR? Well, the OR stands for the organ at risk. And frankly, we have in this case, organs at risk. Remember, prostate sits in front of the rectum, sits underneath the bladder, sits on top of the penis. All of these organs are at risk. And so some amazingly smart engineers went back to the chemistry laboratory and came up with an idea of creating what's called a hydrogel. Basically, I look at it as almost like a, for lack of a better term, oily solution that solidifies temporarily while you're having the radiation. And what this SpaceOAR does is it provides a cushion between the prostate and the rectum in order to help minimize the side effects that are attendant with radiation therapy to both the rectum, the bladder, and the penile nerves. As I said, the rectum is the organ at risk that is really we are concerned about because it can receive a tremendous amount of radiation therapy. As you saw, without SpaceOAR, over 30% of men have debilitating toxicities, bleeding, frequent defecation, diarrhea, urgent urination, and then in the extremely horrific examples, something called a fistula, where there's an actual abnormal connection between your rectum and your urinary stream, not something that you want to have. And these can all, whether it's the most minute diarrhea or the most slight frequency of defecation, can significantly impact one's quality of life, and sadly can affect you lingering on for years to come. What the SpaceOAR hydrogel does is it temporarily positions the rectum away from the prostate and is designed to reduce the amount of rectal wall radiation exposure. So it's almost like a sound barrier so your neighbors don't complain when you have a party. It's inserted in a brief outpatient procedure. So basically, in my hands, what we do is we give the man light sedation, usually a Valium pill. He is placed in the same positioning with his legs up so that I can get at his perineum. After cleaning the perineum, I will numb the skin and place a small probe into the rectum that I could see the rectum itself and the prostate. And I am able to just gently, through the perineum, inject the SpaceOAR hydrogel and see in real time, under ultrasound, while the man is talking to me, the prostate and the rectum move away and separate. And I know when I see that, I know that my radiation is going to be delivered to that prostate and not to that rectum. It's going to help spare the surrounding organs that are at risk because the prostate has been pushed away. After about 6 months, the hydrogel is naturally reabsorbed and removed through the urine. So in other words, your body breaks it down, it metabolizes it, and you urinate it out harmlessly without ever knowing it was there. During that 6-month period of time, you receive your radiation, you get the maximum benefit from the hydrogel, and then when it's not necessary any longer, the hydrogel just goes away. Hydrogel itself is synthetic. It's biocompatible, meaning although it's man-made, it's not made of anything that's harmful to you. It's made of things that are found in biology, not something that are found exclusively in a chemistry book. It's non-toxic. It disappears in about 6 months and made mostly of water and polyethylene glycol, things that are used. Polyethylene glycols are used in artificial tears, for example, and for certain prescription drugs and medical implants. Again, the procedure is brief, takes just a few minutes. I generally do it under a little sedation with local. In some centers, they will put the patient to sleep. It depends on your local practice. It's been clinically studied for quite some time now. And in a research study that got them FDA approval, from what I recall, these patients who received hydrogel were 8 times more likely to have a decline in bowel, urinary, and sexual side effects compared to patients who did not have SpaceOAR at about 3 years. So in other words, those who did not have the SpaceOAR were 8 times more likely to have any of these complaints to the organs at risk that sit right near the prostate. So I want you to think of it this way. With SpaceOAR, one gets more space. And with that more, you get fewer rectal complications, urinary complications, sexual side effects. And with all of those fewers, that adds up to a better quality of life. This is a slide from Boston Scientific, the manufacturers of SpaceOAR, just wanting me to point out to you how safe SpaceOAR is. It's been reviewed in over 75 publications throughout the world. It's used in many of the leading cancer centers throughout the United States and throughout the rest of the world. It's reimbursed by Medicare and, frankly, a growing number, if not most, of private insurance companies. And over 50,000 patients to this point have been treated worldwide with SpaceOAR. I want to pause right now to see what, if any, kind of questions that all of you have. If we don't get to talk directly, because this is a Zoom seminar, please realize that you can always reach me and talk to me through Central Ohio Urology Group. And I have many capable, excellent partners who are more than willing to answer questions at any time.